If you have questions during the presentation, please feel free to type them in the chat window. We'll also leave some time at the end for a question and answer session. So we want to make sure that we cover all the material and then allow some time for some questions at the end. With that, I will introduce you to Elevation UK and today's speaker. This webinar is hosted by Elevation Strategic Development UK. At ESD UK, we work with companies, many like yours, that help navigate clinical, quality, and regulatory challenges, not only in the UK, but throughout the EU and more globally. We're passionate about accelerating diagnostics, the medical space, and pharmaceutical innovations that ultimately improve patient care. Our presenter and expert today is Sabina Patel. She is our co-founder and president of the Elevation Strategic Development UK. She brings extensive experience and expertise in the design and execution of regulatory and product development strategies for companion diagnostics. After working as a technical file reviewer and CDX expert under the IVDR as a notified body, she returned to pharma and led the implementation of IVDR requirements in clinical studies, including pharma-sponsored clinical performance studies. So in this role, she was instrumental in developing IVDR-compliant templates, processes, and advising internally on EU IVDR, CFR 820, and CLIA requirements. So today, Sabina will be talking about the intersection and the complexity of IVDR and the AI Act. So Sabina, I will turn the floor over to you.
Thank you, Jessica. So hello, everyone, and thank you very much for joining us for today's webinar. So as Jessica said, my name is Sabina Patel, and I am President of Elevation Strategic Development UK. So today I'll explore how the IVDR and the EU AI Act intersect with each other, specifically for those digital pathology AI systems, and talk about the specific implications to those from both regulations. And so I'll briefly start by framing the two regulations, then talk about some of the challenges before focusing on what this means in practice for digital pathology AI systems for both manufacturers as well as health institutions, before ending with some foods for thought for some ongoing challenges. Okay, so let's start with a quick refresher on the two regulations at the heart of today's discussion. So I won't spend too long talking about the IVDR because I'm sure that most of this audience, it's familiar territory to most of this audience, but just a few points to emphasize. So the IVDR governs placing IVDs on the EU market. So this includes not just devices that are going to be commercialized, but then also those investigational devices that are being used in performance studies. This regulation came into force on the 26th of May 2022, but we're still in this transition period where not all of the requirements of the IVDR will apply in full. And then based on the release from the European Commission at the end of last year, we also know that the IVDR is in the process of being amended, so we can expect some more changes in the coming years. The IVDR itself classifies IVDs into 4 risk classes from A through to D, with increasing risk attracting increasing levels of regulatory scrutiny. And to this effect, devices that are class B and above will now need to be reviewed and approved by the notified body before they can be commercialized. And then we'll talk about what this means in the context of digital pathology later. The IVDR expects risk management, performance evaluation, and life cycle control or life cycle oversight, which becomes, again, increasingly more important when we compare it to the requirements from the AI Act. For our purposes today, I think the most critical point is the wording in the blue box at the bottom of your slide there. So software is a device under the IVDR, standalone software that provides information that is used to then make diagnostic decisions is an IVD under the IVDR, as I said. So that means that when you have IVDs that implement an AI or a machine learning algorithm that are then used for diagnostic purposes, this will be firmly within scope of the IVDR. It won't be considered an accessory. It will not be considered an add-on. It will be regulated and reviewed as a device in its own right. And this isn't something new that was introduced by the AI Act. This existed even before the AI Act came into effect. And so when we look at the AI Act, this was adopted in August of 2024. And when it was adopted, it became the world's first comprehensive horizontal AI regulation. Like the IVDR, it takes a risk-based approach, but the risk categories under the AI Act are slightly different to the risk categories under the IVDR. And we'll talk about these later in the webinar. The AI Act doesn't replace the IVDR, but instead it layers on top of the IVDR. So it has those requirements that are in addition to the IVDR rather than a reiteration. So for digital pathology AI devices, this creates then a need for a dual compliance framework, very similar to the dual compliance we're used to thinking about in the context of combined clinical studies where you have an investigational device and an investigational drug as part of the same clinical study. The most relevant for today's discussion is the fact that these digital pathology devices that are also regulated under the IVDR will more than likely be high-risk AI systems. And these high-risk systems face a set of slightly more demanding obligations, including risk management, data governance, transparency, human oversight, accuracy, cybersecurity, and we'll delve a little bit deeper into some of these later in the webinar. Crucially, the AI Act tells us that AI systems, which are components that are regulated under existing EU harmonised legislation, of which IVDR is one of those harmonised legislations, are automatically classified as high risk, which is why we say that the digital pathology devices are almost always going to be high-risk AI systems. So if your AI-enabled IVD is already regulated under the IVDR, the AI component by definition will be a high-risk AI system under the AI Act. There's sadly no separate risk assessment for this classification. So at first glance, there is clear overlap between the two regulations. Both regulations have a keen focus on risk management. They require the post-market surveillance and monitoring activities, and documentation is at the heart of both of these regulations to make sure that the documentation is compliant with QMS. But the concept of clinical performance isn't really introduced in the AI Act. But what the AI Act does is introduce slightly new concepts around that are more relevant to these AI devices, particularly around training and data governance, bias mitigation, transparency, and explainability of the algorithm, none of which are explicitly addressed in the IVDR. So this slide shows where the IVDR and the AI Act don't quite see eye to eye. So under the IVDR, we already know that risk management is central to GSPR compliance and that your ISO 14971 compliant risk management system will need to evaluate the risks posed by the device in the context of the device intended purpose. This is a similar concept under the AI Act, but and then similarly, and also under the AI Act, risk management will need to be a continuous iterative process, so needs to continue for that lifetime of the device. Unsurprisingly, though, the focus under the AI Act specifically calls out AI relevant risks. So this is looking at bias, performance drift over time, cybersecurity attack, and risks arising for both intended use and reasonably foreseeable misuse. Again, that last bit is also relevant to the IVDR. Data governance is likely where many manufacturers will feel the most pain. The IVDR is outcome focused, and manufacturers have to demonstrate the device works, that it correctly identifies the biomarker in the intended use population. And then when you have companion diagnostic devices, you need to demonstrate that the device is essential for the safe and effective use of the corresponding drug. This is demonstrated through scientific validity, analytical performance, and clinical performance, all of which together make up the clinical evidence and performance evaluation for the device. The AI Act looks at this through a slightly more different lens. So whilst the IVDR is slightly more outcome focused, the AI Act is process focused. So the AI Act tells us that the training, validation, and testing data sets need to be relevant. They need to be representative of the population that will be tested or used, that the algorithm will be used on. And also that the algorithm needs to be free of errors, which means that there needs to be a sufficient amount of validation that goes into the development of these algorithms before they can be released. So this needs to take demographic variations into account, as well as any bias detection by the algorithm or from the algorithm. This in itself is a huge lift from the IVDR, because in theory, if you do this, or if manufacturers tackle these separately, in theory, you could have an AI-enabled IVD that passes all of its clinical performance studies and all of the verification studies with flying colours, but then it fails to meet the requirements under the AI Act. And this could be because of very simple reasons, such as the transparency or the annotation process not being sufficiently documented, or not using a demographic representative data set. So this will create new documentation burdens around dataset provenance and annotation quality, as well as making sure that the demographics are appropriately represented, that go well beyond what the IVDR alone demands currently from manufacturers. And then we have the requirements around transparency and explainability. The requirements around this is one that maybe I think will probably keep AI developers up at night. With its explainability requirements, the AI Act moves away from this black box approach. So usually we know what the output of the algorithm is, but not really why it has come to the conclusion that it did. The AI Act also requires the AI system to be designed so that users can appropriately interpret their outputs. So when we think about an IVD device and the user of an IVD device, these are most likely going to be lab professionals or clinicians. So, and then what the IVDR AI Act, explainability and transparency requirement tells us is that these lab professionals or clinicians need to be able to understand what the AI algorithm is telling them, and crucially, when they should and shouldn't trust it. What we don't know currently is how much explainability will be enough for the regulators. And then finally, we have the continuous learning requirement, which may also pose a bit of a challenge, simply because whilst continuous lifecycle management is expected under both the IVDR and the AI Act, the way in which this is approached is slightly different by both regulations. So the IVDR is built around this concept of a locked device. You develop the device, you lock it, you assess it, you certify it, and then generally once it's commercialized, it stays as it was when it was certified. There are exceptions to this, and we absolutely have processes for substantial modifications. But as a general rule of thumb, even once it's modified, the system is still locked, the device is still locked before it's commercialized. On the other side, many AI models are designed to learn and improve over time. And then in the US, you have the concept of this predetermined change control plan, or the PCCP. Currently, there's no indication of a similar concept for the EU. So whilst this is still an emerging area, it's absolutely something you should be building into your regulatory strategy and your development plan in terms of how this continuous learning will be applied for digital pathology AI devices, given how the IVDR approaches devices versus the AI Act. And then to delve into one of these a little bit more, because I feel like it probably signifies the convergence and divergence of the IVDR quite well, is that when we look at the human oversight requirements through the lens of both the IVDR and the AI Act, the distinction between them is quite clear. Under the IVDR, oversight is embedded within safety and performance requirements. So we have the GSPRs, we have the usability engineering, you'll have the performance evaluation, clinical performance, all performed in the context of your intended purpose. The focus here is quite technical. Continuously, you're asking, does the device perform as intended, and are the risks acceptable when the device is used as it is being intended to be used? On the other hand, the AI Act expands on this. So what it does is it introduces a slightly more behavioral and cognitive dimension to this perspective. So the AI Act and what it requires for algorithms is not only concerned with whether the AI works and do you get the result that you need at the end of it, but how humans respond to that. So under the IVDR, we will validate our device through the verification studies. You will, if there are any instrument or device interfaces, you assess those as well, and then you assess the performance limits of the device. Under the AI Act, we need to consider the actions of the user. So will the users become overly reliant on the output from the algorithm, or are they able to humanly or override the output from the AI algorithm when they believe it's meaningful? And this needs to be doable in practice rather than just technically possible for them to do. So in short, really where the IVDR, asks, is the device safe and effective? The AI Act asks, how does the human AI interaction introduce new risks? So slightly different dimension to how we approach the human oversight and usability studies. So when we look at this in the context of digital pathology, this becomes highly relevant. If an AI triage tool flags slides as low risk, so for example, the device is used to identify slides that may have cancer cells on them, this would then influence how thoroughly those slides are perhaps reviewed by the pathologist, and that behavioral effect may become part of the regulatory risk profile. So does the pathologist then pay more attention to those slides flagged as high risk or containing cancer cells versus those that are flagged as low risk, i.e. containing no evidence of cancer cells? And so for manufacturers and labs, that layering is where the real regulatory complexity now sits, because then you have to distinguish what's needed from the IVDR and then overlay what's needed from the AI Act in terms of the explainability, transparency, oversight, etc. requirements. So let's take a deeper dive into what this means in the context of digital pathology devices. So like the US, the IVDR breaks down digital pathology systems into their, unlike the US, the IVDR breaks down digital pathology systems into their individual component parts. So you've got your whole slide scanners, you've got your display, you've got your viewing software, you've got your image management tools, and then you may have some additional diagnostic software on top of that. Where the US sees this as a whole system, the IVDR allows manufacturers to classify these in a modular approach, and so each of these are classified separately. So what this means is that each of these individual components could fall under a different risk class depending on the intended purpose and the impact of incorrect results in the context of the intended purpose. So under the IVDR, as I said earlier, we have 4 different risk classes. So we've got A through to D, where A is the lowest lowest risk class, where you have lowest personal and public health risk, all the way through to class D on the opposite side, for which represents the highest personal or public health risk. So, for example, you could have a display screen that in the first instance is a class A device, because all you are doing is using this screen to visualize your slide. You're not using it to make any treatment decisions or any make any inferences around patient management. But as soon as you use the same viewer to now, you're also still visualizing the slide, but now you're visualizing that slide to make cancer treatment decisions, for example. When you do this, this device then moves into a class C device, because now you're using it for cancer care. So the higher the risk, the greater the regulatory scrutiny, as you will be aware. Classification isn't always straightforward, though, and usually involves judgment calls that depend on the specific intended purpose, the claims that you want to make with the device, and the clinical context of use. So as I said on my previous slide, the same viewer can be both a Class A and a Class C device, depending on what you want to do with it. And so under the IVDR, device classification is driven by the intended purpose. And the key thing here is the role the device plays within that clinical decision-making process. As the intended purpose changes, you need to continually reevaluate to make sure that the classification of the device is still matching the intended purpose of the device. So the complexity of the software essentially has nothing to do with device classification under the IVDR. It is still, even for digital pathology devices, driven by the intended purpose of the device. So let's bring this into slightly sharper focus with an example from digital pathology viewers. So where you have a viewer that's used only to display whole slide images, so whether that's for research purposes or for archival purposes or for using in teaching or seminars, this kind of a device would typically be a Class A under the IVDR. It doesn't interpret data, or it isn't used to directly influence any clinical outcomes for the sample. And so an example of something that does this would be something like the Philips pathology viewer that's used in the non-clinical setting, so in the research setting. These viewers are low risk, and because they're Class A, they can continue to be self-certified even under the IVDR. But the moment you extend the intended purpose, so for example, now you're using that viewer to integrate decision support overlays, or you're using that viewer to make to perform clinical interpretation, the classification of this will also change. So for this, we can use the page viewer along with the page prostate to illustrate how that changes. So by itself, the page viewer, likely a Class A device, but when the page viewer is used in conjunction with the page prostate, now you're not just displaying image, you're helping pathologists detect and evaluate cancer. So then this would now become a Class C device because it's being used to directly inform diagnosis or treatment. And this is a really important distinction and something that manufacturers need to bear in mind, because the classification that the device starts its life as isn't static. So as the intended purpose changes, you need to continually reevaluate the classification to make sure that that is now reflective of the revised intended purpose, which sometimes raises some challenging questions, right? So are the classification rules really keeping up with real-world use cases? And the answer to the classification question isn't always clear. And that's why we have the MDCG guidance, and where this becomes really vital. So MDCG guidance documents on software. So we have MDCG guidance on software qualification and classification, and these should be essential references for not just software manufacturers, but also digital manufacturers of digital pathology devices. So, for example, we have MDCG 2019-11, which outlines how to interpret the intended purpose for a device and what constitutes diagnostic functionality in your software. And that will help you then identify which of these classification rules are most applicable to your device. So let's now change tracks a little bit to talk about the AI Act, which currently coexists alongside the IVDR. So for manufacturers of AI-based pathology tools, this intersection is critical because you have your dual compliance framework, as we talked about. The AI Act introduces a new compliance dimension for digital pathology devices, pathology manufacturers, in particular those manufacturers that then have an AI component built into their digital pathology device. Devices are already regulated under the IVDR, and as I said earlier in the presentation, when you have an IVDR-regulated device with an AI component, this is automatically considered a high-risk AI system under the AI Act. This means that manufacturers will have to implement robust transparency, monitoring, and human oversight measures in addition to CE marking. It's also important for users, including clinicians and hospital IT teams, because you could, whether it's intentional or unintentional, you could become legal manufacturers of the device if you modify or repurpose the AI system to what it was originally intended for. So the implications are significant, and we'll talk a little bit more about this later in the webinar. So navigating this dual framework is critical to bringing your AI-based digital pathology tools to the market safely and legally under both of the regulatory frameworks. And so similar to the IVDR, the AI Act has 4 risk classifications. And this risk classification, or this pyramid, essentially illustrates the core philosophy of the AI Act. The regulation is proportionate to the risks. So what you need to do for your device is proportionate to the risk posed by the device. So at the bottom here, we have minimal risk systems with no additional regulatory obligations, because the AI Act acknowledges that there is little to no risk posed by these devices. Then we have limited risk systems, which are subject to transparency requirements. And then we have high risk AI systems, which, as I said earlier, includes most medical AI and digital pathology systems. These high-risk systems need to meet extensive regulatory requirements, some of which we've talked about already, and some of which we'll talk about in the coming slides. So AI that are used in medical devices are high risk because of the potential to impact patient health and safety. So these devices are being used sometimes for patient management decisions, and therefore they are classified as high risk. And then at the top of the pyramid, we have unacceptable risk systems, which are prohibited entirely within the EU. So they don't have any regulatory requirements to comply with, because anything classed as an acceptable risk will not be marketable in the EU. Sorry. So what does all of this mean, not just for manufacturers of these systems, but also for the users? So manufacturers shouldn't treat the AI Act as an add-on to the IVDR. Instead, the preferred approach would be to integrate those AI risk management requirements into your ISO 14971 risk management file, so that you don't have separate risk analyses for the algorithm versus the IVD component of your device. Also, manufacturers should explicitly address any training data representativeness, including modeling the update strategies and making sure that the demographic data or the demographics of the population are accurately represented. Manufacturers should also consider having a single post-market surveillance plan, which meets the needs of both the IVDR and the AI Act. And then finally, as the AI device would be subject to dual compliance requirements and needs to be reviewed by the notified body under both of those regulations, you should ideally contract with a notified body who is qualified to perform reviews under both regulations. So again, allowing you to streamline that review process. Some hospitals also develop internal AI tools. So these AI tools are not always going to be commercially available. Under the IVDR, we have Article 5.5, which clarifies the exemptions for single health institutions. And these can, in part, be applied also to digital pathology devices that use an AI component, but then that scope will be narrow. So we know that for a device to qualify for the single health institution exemption, it needs to be used within a single health institution that's based in the EU, and that the device cannot be transferred to another legal entity. This remains the case even when you have a digital pathology device with an AI component. You also need QMS compliance with ISO 15189, ideally with certification. So if your IVD device in your single health institution has an AI component, you then also need to consider which aspects of these apply. So in this example, where the device is implemented in that single health institution under Article 5.5, as the device isn't subject to notified body review, this wouldn't really be classed as a high-risk device under the AI Act. And the reason for this is that the AI Act tells us, Article 10 of the AI Act tells us that it's those devices that are regulated under those EU harmonized legislations, so such as the IVDR, which then automatically become high-risk systems. So when you have a device that is benefiting from the exemptions under the IVDR, the assumption here is that you would also then benefit and apply that to the AI Act. The AI Act, as I alluded to earlier, also introduces explicit obligations for the user. Pathology labs need to ensure that pathologists understand the limitations of the device. Ideally, these devices should be used according to their IFU without any changes. And it's really important to remember that if the user makes a change, whether that's accidental or on purpose, as soon as that change is made, it may mean that the the lab now becomes the legal manufacturer of the device. So then you, as the manufacturer of the device, you then may take on those obligations of the legal manufacturer. Aside from this, the user needs to monitor for performance drift and maintain oversight during use of the device, again, to make sure that there is no performance drift, there's no bias introduced, and that the human oversight remains intact. And there is a requirement to report any serious incidents that occur within the lab through as part of using the device. So the labs should also document all of their decision-making processes. And this isn't really a new requirement. It exists under the IVDR. It exists whenever you develop any diagnostic device. Usually this is an important safeguard for manufacturers as well as users. But when you document these decision-making process, this shifts some responsibility from the manufacturer to the user, in particular when you're making changes to the device. So you need to make sure that the rationale is adequately documented. And then when we talk about human oversight under the AI Act, it's important to understand that this is not just superficial. It's not just a superficial requirement. Human oversight is not satisfied simply because the pathologist clicks confirm at the end of the workflow. For digital pathology AI systems, that means that several things have to happen in practice. First, the AI output needs to be reviewable. The pathologist must be able to see how the AI reached its conclusion, or how the algorithm reached its conclusion, whether that's through heat maps or through highlighting particular regions of interest. There needs to be some form of an explainability feature built into the AI system. A black box output with a binary result and no context simply will not do under the AI Act because it doesn't support the requirement for meaningful human oversight. The pathologist also needs to be able to override the AI output, so not just technically, but practically. So it's not adequate for the AI algorithm or the manufacturer to state in their IFU that this should be technically feasible. The pathologist should be able to easily see how they can override any of the AI output. And so and then the pathologist, also needs to show that they aren't becoming overly reliant on the output to prevent that automation bias. So again, bringing into focus the explainability and transparency and marrying it with the bias requirements. The regulators will be particularly sensitive to making sure that automation bias isn't creeping in to the AI algorithm and regular use of the AI algorithm. And then there needs to be clear safeguards against blind acceptance of the output from the algorithm. So, for example, this can be achieved through lab SOPs or work instructions which make it very clear how decisions or outputs can be overridden. So at the very least, you want to make sure this doesn't happen to prevent the pathologist from becoming de-skilled, because now they are very used to the algorithm or the AI digital pathology tool, evaluating the slides, understanding any complex morphologies, understanding which are cancerous cells, etc. And this is particularly relevant where you have high volume cancer diagnostic centres. If the AI algorithm and digital pathology tool is used to pre-screen or prioritize cases, there is a risk that negative cases will receive less scrutiny. So as we talked about earlier, this is perhaps something that the regulators are quite sensitive to and will make sure and will perhaps scrutinize to make sure that slides that are being identified at high risk are not being scrutinized any more heavily than those slides that are being classified as lower risk by the AI algorithm. So for both manufacturers and lab users, the question becomes, can you demonstrate that the user remains meaningfully in control of the algorithm rather than the algorithm telling the user what needs to happen at every stage? And this essentially is at the heart of human oversight under the AI Act. So in addition to this, we still have a number of open questions as we navigate through the complexities of both the IVDR and the AI Act. So for example, there are currently no harmonized standards under the AI Act with with fewer standards harmonized under the IVDR Act. I won't say no standards because we do have some standards harmonized under the IVDR, but perhaps not as many as we would like. With these, will these standards then eventually be aligned to prevent any mismatch between the two regulations and any mismatch of requirements from the two regulations? Because the IVDR mandates Additionally, the IVDR mandates the demonstration of clinical performance through the performance studies. You don't really have a similar concept under the AI Act, although the AI Act does talk about verification and making sure that the algorithm is appropriately validated. So this really begs the question around how investigational digital pathology devices with an AI component, whether they can be used in a clinical performance study and whether that will be compliant with both of the regulations. And then finally, I briefly talked about single health institution exemption earlier in the webinar. This under the IVDR greatly reduces manufacturer burden. There isn't really a mention of an equivalent provision under the AI Act, in particular when you are developing and validating the AI tool. So are there any risks of using these systems in single health institutions that we just aren't aware of at the moment? So to conclude, most digital pathology AI systems will likely be Class C devices under the IVDR if they are being used in the clinical decision-making pathway. And then for this fact alone, they would then automatically qualify as a high-risk AI system under the AI Act. The IVDR remains focused on device safety and clinical performance, making sure that the product does what it claims to do, whilst the AI Act essentially adds a layer on top of this by regulating the AI system itself. So the AI system essentially scratches below the surface to look at the training data set, the bias risk, the robustness, and critically, the interaction between the human user and the algorithm. Compliance with the IVDR doesn't automatically equate to compliance with the AI Act. As we've talked about throughout the webinar, there are some similarities, but then there are also key differences which will require manufacturers and users to take additional actions for compliance under the AI Act. Manufacturers should ideally have an integrated lifecycle governance system that aligns the requirements under both the AI Act as well as the IVDR to make sure that you are effectively compliant with both regulations. So for users, oversight and operational responsibility are now explicitly regulated as well under the AI Act. And essentially, proactively integrating requirements is always the key to success, and the AI Act with the IVDR is no different. And with that, I would like to thank you for your